So imagine this. You've got a 34-year-old guy sitting in a restaurant.
Okay, pretty standard setup.
Right. And he takes a bite of chicken, chews it totally normally, swallows, and then he just stops.
The food is stuck.
Exactly. It's completely stuck. And not because he, took too big of a bite or forgot to chew. It's stuck because, like, a single pollen spore he inhaled 3 weeks ago while he was out jogging
Oh, my man, yeah.
triggered this microscopic demolition crew, and they literally paved over the inside of his esophagus with this rigid, unyielding scar tissue.
I mean, it sounds like absolute science fiction when you put it that way.
It really does.
But for a surgeon, and specifically for you listening right now, that scenario is a highly specific, rapidly escalating reality in the emergency department. Like, the presentation is mechanical,
yeah.
but the root cause is this deeply complex immunological cascade.
And if you are listening to this deep dive today, we know exactly why you're here. You are the senior surgical trainee or, maybe the PhD candidate who is just completely entrenched in preparation for the FRCS exam.
We know the stakes. They are incredibly high.
Yeah, passing at this elite level means you can't just memorize a list of symptoms anymore.
No, absolutely not. You have to understand the fundamental architecture of the disease, the exact molecular pathways that drive it.
Right, and the precise stepwise management required so you don't inadvertently cause, catastrophic harm in the operating room or the endoscopy suite.
Because the difference between passing and failing the FRCS often comes down to understanding the why behind the what. I mean, a technician knows how to inflate a dilation balloon.
Mm-hmm.
But a master clinician knows why inflating that balloon at the wrong time will literally tear the patient's esophagus to shreds.
Wow. And that is exactly the level we are operating on today. Looking at your source stack, you have given us a really fascinating dichotomy to explore.
It's quite the mix.
It is. On one hand, we have this dense, highly definitive clinical text titled Eosinophilic Esophagitis: Pathogenesis, Diagnosis, and Clinical Management.
A heavy hitter, for sure.
Oh, yeah. We are going to tear this thing apart, moving from the macroscopic presentation in the ER all the way down to, the genetic mutations on the male X chromosome.
But then, and this is the interesting part right next to it in your study notes, there is a completely unrelated, incredibly striking image.
Yeah, it's a photo of a stone memorial dedicated to Victoria Cross Indian recipients set in this really tranquil, lush garden.
The juxtaposition is just striking. On one side, we are dealing with microscopic, chaotic, chronic internal warfare.
Right.
And on the other, you have this profound, grounded, macroscopic stillness and historical reflection.
So our mission today is to tackle both. First, we're going to build a comprehensive, high-level mastery of eosinophilic esophagitis EoE.
Arming you with the pathophysiology, the rigid diagnostic criteria, and the management strategy.
Exactly. Everything you need to elevate your clinical practice. Then, once we've survived the clinical gauntlet, we are going to use the visual details of that memorial image as a necessary psychological anchor, like a reflective counterpoint to the intensity of your medical review.
It's much needed after going through the EoE literature, honestly.
Okay, let's unpack this. To really understand EoE, I want to start with that guy in the restaurant choking on the chicken. Because for decades, the medical community just fundamentally misunderstood what was happening to him, right?
Oh, completely. We really did. And the historical context here is crucial because it represents a massive paradigm shift in gastroenterology and esophageal surgery.
How so? What were we doing wrong?
Well, for a very long time, if a patient presented with esophageal complaints, dysphagia, heartburn, or food impaction, the medical community reflexively just tossed it into the bucket of gastroesophageal reflux disease.
Standard GRD.
Exactly, GRD.
Mm-hmm.
If they had these weird stubborn strictures and high eosinophil counts, we just called it a bizarre refractory phenotype of GOD.
So the assumption was just that acid was splashing up from the stomach, burning the tissue, and causing chronic inflammation.
Yes. We basically view the esophagus as a passive biological transit pipe.
Just a tube connecting the mouth to the stomach.
Right. And that passive pipe model was the foundational error. The paradigm shift outlined in your text is the recognition that the esophagus is actually a highly active immunogenic organ.
Wait, immunogenic? Like it has its own immune system?
It possesses its own complex immune surveillance system, yes. So EoE is not an acid burn. It is a distinct chronic immune or antigen-mediated process. It is a completely separate entity from GEOE.
And the text highlights an epidemiological profile that makes this distinction incredibly clear. Because, I mean, GEOEThe affects a massive broad swath of the overall population.
Almost everyone gets heartburn at some point.
Exactly. But EoE, the demographics are shockingly specific. It's reported worldwide, incidence of 0.1 to 1.2 per 10,000. But when you look at who is actually walking through the hospital doors, it's not an even spread.
Not at all. It leans heavily toward very specific populations. In pediatrics, the data shows a massive skew toward boys. And in the adult population, the statistics are just stark. It is predominantly a disease of Caucasian and non-Hispanic white men.
Oh.
The source notes they are affected at a rate of 76% compared to 48% in women of those respective demographics.
76%. That's a huge skew. And the timeline of presentation is just as specific, right? The clinical text notes it peaks in their 20s and 30s, with the mean age of diagnosis being exactly 34.
Which brings us right back to our hypothetical guy in the restaurant.
Right. If a 34-year-old Caucasian male comes into the ED with solid food impaction, EoE shouldn't just be, like, casually on the differential.
It should be flashing in neon lights. It has to be the primary suspect. But we really need to dig into the etiology, because the trigger for this immune response is what trips up a lot of diagnosticians on the exam.
Okay, let's get into it.
The text points to a triad of environmental, genetic, and host immune factors all interacting. And the environmental trigger is often a food allergy or an aeroallergen.
Okay, this is where I want to push back a bit, or rather, where I think a lot of people get conceptually tangled up.
Go for it.
If the text says this is triggered by a food allergy, why isn't this guy going into standard anaphylaxis? I mean, when we hear food allergy, we picture someone eating a peanut, their airway swells shut, their blood pressure plummets, and they need an EpiPen immediately.
Right, the classic peanut allergy reaction.
Yeah, but that's not what's happening in EoE. So how does this chronic immune response differ from the acute reactions we usually associate with the word allergy?
This raises an important question, and parsing the difference between those two immune responses is absolutely vital for the FRCS candidate. You have to separate the concept of allergy into two completely distinct pathways.
Okay, walk me through it.
Anaphylaxis is an acute IgE-mediated response, immunoglobulin E. It's explosive, it's systemic, and it's immediate.
Yeah.
Mast cells degranulate all at once, releasing massive amounts of histamine.
So it's like an all-hands-on-deck, system-wide alarm.
Precisely. EoE, on the other hand, is a chronic, mixed, largely non-IgE-mediated immune response.
Non-IgE.
Right. It is a slow burn, driven by a completely different subset of cells. Instead of acute anaphylactic shock, these patients have a much more insidious presentation. The text notes a very strong correlation with a broader history of atopic.
Atopy. So when you are taking the clinical history in the ED, you aren't just asking about the piece of chicken they just choked on. You're looking for the atopic march.
You are asking about chronic seasonal allergies. You are asking about childhood asthma, atopic dermatitis, eczema, allergic rhinitis.
Basically any history of allergic hypersensitivity.
Exactly. It is the underlying atopic diathesis, that genetic predisposition to hypersensitivity manifesting specifically in the mucosal tissue of the esophagus.
Which means we need to trace this back to the blueprint. We know who is getting it, and we know it's a non-IgE slow burn immune response. I want to dive into the molecular battlefield now, because the genetics here are literally the smoking gun for why those specific demographics are hit so hard.
The pathogenesis has a profound genetic component. There is high concordance among family members, suggesting this isn't just bad luck. It's hardwired.
Right.
The breakthrough actually came from genome-wide microarray studies. They were looking for the specific localized trigger, and they found a heavily overexpressed gene in these patients.
The TSLP gene.
The TSLP gene, exactly.
Thymic stromal lymphopoietin. When I was reading through the source material, the location of this gene made the entire epidemiological profile suddenly click into place for me.
Oh, it's fascinating.
Yeah, the TSLP gene is located on the 5q22 region, but more importantly, it's heavily implicated on the male X chromosome.
And there it is. The genetics perfectly explain the epidemiology. That heavy skew toward boys in the pediatric ward and the 34-year-old men in the ED, it's rooted right there in the 5q22 region.
So let's walk through the mechanistic pathway, because for a surgeon, understanding how a microscopic pollen spore or a milk protein turns into a rigid fiber stricture, that's the whole ballgame.
It really is. It starts with an antigen exposure. Yeah. The antigen, let's say a specific food protein, interacts with the esophageal epithelium. In a genetically susceptible individual, That TSLP gene goes into overdrive.
So it's hyper-reacting to something normal?
Exactly. Thymic stromal lymphopoietin is a cytokine that acts essentially as an alarm bell for the immune system, but it specifically stimulates Th2 cells.
T helper type 2 cells. And this is where the shift from the acute IgE response to the chronic slow burn actually happens.
Right. The activated Th2 cells become the generals of this localized war. They begin releasing a highly specific cascade of pro-inflammatory cytokines: interleukin-5, interleukin-13, and interleukin-15.
IL-5, IL-13, IL-15. Got it.
Each of these plays a distinct role, but IL-13, for instance, is notorious for disrupting the epithelial barrier function, making the tissue even more permeable to antigens.
Oh, wow. So it's basically sabotaging the fortress walls from the inside.
That's a great way to put it. But the Th2 cells do something else that is arguably the most critical step in this entire disease process.
What's that?
They induce the esophageal mucosa to overexpress a chemokine called eotaxin-3.
Eotaxin-3, the homing beacon.
It's literally a taxi for eosinophils.
Right. It creates this chemical gradient that pulls eosinophils out of the bloodstream and directly into the esophageal tissue. And this is a massive physiological violation, right?
Absolutely.
Because as the text explicitly states, the normal healthy esophagus completely lacks eosinophils.
Zero. None. If you see even one eosinophil in the esophageal mucosa, it is by definition pathologic.
Because they're supposed to be somewhere else.
They belong in the GI tract, yes, but much lower down in the stomach and intestines to fight off parasites. The esophagus is supposed to be a sterile transit tube in terms of eosinophilic presence. So when eotaxin-3 recruits them there, they are invaders.
And they don't just sit there politely either.
No, they do not.
Eosinophils are packed with highly toxic basic granules, things like major basic protein, eosinophil peroxidase. When they arrive in the esophagus and degranulate, they cause massive local tissue damage. But from a surgical perspective, the real villain of this story isn't just the tissue damage. It's the body's attempted repair process.
You're referring to the secondary cytokine release.
Yes.
Once the eosinophils and recruited mast cells have infiltrated the tissue and set up CANK, they begin releasing TGF-B, transforming growth factor beta.
TGF-B. You know, I was trying to conceptualize TGF-B based on the clinical text, and the best analogy I could come up with is a rogue construction crew.
Okay, I like that.
Because it's like the body detects this minor threat, the food antigen, and instead of sending a single security guard to just escort the antigen out, the Th2 pathway panics.
It overreacts completely.
Right. It calls in an aggressive demolition and paving crew. And that paving crew is TGF-B.
Because the normal biological function of PGFB is to stimulate fibroblasts, to lay down collagen and extracellular matrix. It's meant for wound healing.
But here, the wound never goes away because the antigen exposure is chronic. The guy keeps eating chicken or dairy or breathing pollen. So the TGF-D paving crew just keeps working.
They never clock out.
Exactly. It keeps laying down thick, fibrous concrete inside the delicate layers of the esophagus. It causes subepithelial fibrosis and smooth muscle dysfunction.
The clinical term we use is remodeling. The inflammatory phenotype transitions into a fibrostenotic phenotype.
Fibrostenotic, so it gets stiff and narrow.
Exactly. The smooth, pliable, muscular tube of the esophagus is fundamentally altered. It becomes rigid, fibrotic, and mechanically dysfunctional. This is exactly why the patient experiences dysphagia. The esophagus can literally no longer stretch to accommodate a bolus of food.
And this brings up a detail in the text that I found genuinely staggering. It really speaks to just how hypersensitized this entire pathway is.
Which part?
Well, we've been talking about food triggering this in the esophagus,
Yeah.
swallowing things. But the text notes that a single exposure to an airway or cutaneous antigen can lead to eosinophil recruitment in the esophagus.
Yes. It highlights the profound interconnectedness of the mucosal immune system.
Just to be totally clear, cutaneous means skin. You're saying a patient could just touch something they're allergic to or inhale a specific aeroallergen, and that peripheral exposure triggers a systemic cascade that ends up paving over the inside of their throat with fibrous scar tissue.
I am. The atopic diathesis isn't geographically confined.
Wow.
An antigen presenting on the skin can activate dendritic cells. Those cells migrate to the lymph nodes, prime those Th2 cells we talked about, and because of that genetic predisposition on the 5q22 region, Those Th2 cells specifically target the esophagus with eotaxin-3.
That is just terrifying from a management perspective. It means the patient is constantly navigating a minefield. The trigger isn't necessarily just something they are chewing and swallowing.
It's a whole body immune vigilance issue.
So the structural remodeling is happening, the
Yeah.
TGF-B is laying down collagen, the lumen is actively narrowing. Let's transition from the cellular pathology to the actual clinical reality.
Let's do it.
Let's walk through the diagnostic gauntlet, because diagnosing this, from what I read, is notoriously treacherous.
It requires extreme precision. As we discussed, adults typically present with solid food impaction or dysphagia, sometimes chest pain that perfectly mimics a cardiac event or severe reflux.
Right.
But we really have to contrast that with the pediatric presentation, which is far less mechanical.
Yeah, because kids aren't usually getting a massive piece of steak stuck in their throat. The text notes pediatric patients present with nausea, vomiting, abdominal pain, food intolerance, and weight loss.
It's insidious. A child might simply be branded a picky eater or diagnosed with failure to thrive.
That's sad.
It is, when in reality, eating causes them profound discomfort because their esophagus is inflamed and swollen. It requires a really high index of suspicion from the pediatrician to look beyond simple reflux.
And once you suspect it, you can't just guess. The clinical text establishes a rigid diagnostic triad. You must satisfy all three criteria definitively.
Non-negotiable.
Clinical presentation is only the first part. You need positive findings across clinical, endoscopic, and histopathologic examinations.
You cannot diagnose EoE on symptoms alone, nor on endoscopic visuals alone, nor solely on a biopsy. The integration of all three is mandatory.
And the first major hurdle in this evaluation process, and this is a massive high-yield concept for the FRCS, is the PPI trial, proton pump inhibitors.
Yes. If you have a patient presenting with these symptoms and you suspect EoE or GERD, the mandatory first step historically and diagnostically is to place them on optimal PPI therapy.
Okay, let's define optimal, because we aren't just talking about popping an over-the-counter antacid after a heavy meal.
No, the clinical protocol is aggressive. We're talking 20 to 40 milligrams of a PPI taken orally twice daily for a strictly monitored duration of 8 to 12 weeks.
Now, I want to dissect the mechanism here, because this is where a lot of trainees get tripped up.
Okay.
If we know EoE is an antigen-mediated immune disease, not an acid burn disease, why are we giving them a drug designed to suppress stomach acid? Why would a PPI help an allergic reaction?
That is a brilliant question. And understanding this nuance is exactly what separates the superficial reader from the expert. For a long time, we thought the PPI trial simply ruled out GERD.
Right, like a binary test. If the PPI cured them, it was GERD. If it failed, it was EoE.
Exactly. But the biological reality is far more complex.
Because PPIs actually have an independent anti-inflammatory effect, don't they?
Precisely. Proton pump inhibitors, completely independent of their acid-suppressing capabilities in the stomach, have been shown to block the STAT6 pathway in esophageal epithelial cells.
The STAT6 pathway.
Right. And by blocking STAT6, the PPI directly inhibits the expression of eotaxin-3.
Oh, wow. So you are using a stomach acid drug to chemically jam the homing beacon that is pulling the eosinophils into the esophagus.
Yes, you're cutting the taxi line. This created a massive diagnostic confusing category for years called PPI-responsive esophageal eosinophilia.
Because doctors didn't know if it was GERD or EoE.
Exactly. Were these patients suffering from GOD that was causing eosinophilia, or EoE, that was miraculously responding to PPIs? Current consensus recognizes that a subset of true EoE patients will respond to PPIs purely because of that anti-inflammatory eotaxin-3 blockade.
That is fascinating.
However, for the classic immune-mediated EoE patient we are discussing today, they will fail this 8 to 12-week trial. The symptoms and the eosinophilic infiltration will persist despite the high-dose PPI.
Okay, so the patient has taken high-dose PPIs for 2 months. They come back to clinic. They still can't swallow properly. It is time to go in. We move to the second leg of the triad, the endoscopic evaluation.
Time to take a look.
And the descriptions of what you see through that camera are incredibly vivid.
When the macroscopic changes are present, they are unmistakable. You will observe longitudinal mucosal furrows, these deep grooves running vertically down the esophageal wall.
Like tire tracks in the mucosa.
Yes. You will also frequently see fixed esophageal rings. We refer to this as trachealization because the esophagus literally takes on the ribbed cartilaginous appearance of the trachea.
Which goes right back to the TGF-B. That rogue paving crew has laid down bands of fibrous tissue, turning a smooth, distensible muscular tube into a stiff ribbed pipe.
The fibrosis severely restricts the dilation of the organ. You might also see whitish mucosal plaques or exudates, which are actually microabscesses of eosinophils clustered near the surface.
Yikes.
And you will see a diffusely narrowed lumen. But the most terrifying finding for an endoscopist is what the text describes as crepe paper mucosa.
Crepe paper, just the visual of that tissue paper that is thin, crinkled, and incredibly delicate.
The inflammation and the destructive enzymes from the eosinophils degrade the structural integrity of the mucosa to the point of extreme friability. Simply advancing the endoscope or the minor trauma of just taking a biopsy can cause a superficial mucosal tear. The tissue just shears away.
That mental image should make any surgeon's heart rate spike when considering intervention.
It absolutely should.
But there is a massive diagnostic trap here that the text warns about. You have this patient with severe dysphagia. They failed the PPI trial. You scope them expecting to see trachealization and crepe paper, and what happens?
The esophagus can visually appear 100% normal.
Wait, really? I find that astounding. You have an immune war raging in the tissue, massive fibrosis, but the mucosal surface looks pristine and pink to the camera.
It is one of the most dangerous pitfalls in gastrointestinal diagnostics.
Yeah.
Macroscopic appearance does not reliably correlate with microscopic disease.
Wow.
You can have a perfectly smooth-looking esophagus that is absolutely packed with the eosinophils beneath the surface. This is why the biopsy protocol is an unbreakable rule.
You cannot just look. You must take tissue.
Always.
And the protocol outlined in the text isn't just grabbing a quick sample randomly. It is a highly specific geographic mapping of the upper GI tract.
The disease process is notoriously patchy. If you take one biopsy, you might hit a healthy patch of mucosa and entirely miss the disease, resulting in a false negative.
Which is a disaster for the patient.
Exactly. Therefore, the protocol mandates taking multiple biopsies from the proximal, mid, and distal esophagus.
But the protocol goes even further, and this is another crucial concept for the FRCS exam. During that same endoscopy, while you are down there, you are required to advance the scope past the esophagus and take biopsies from the antrum of the stomach and the duodenum.
Yes.
If the patient's symptoms are entirely localized to the esophagus, why are we taking tissue from the stomach and the small intestine?
To rule out a systemic issue, the defining hallmark of eosinophilic esophagitis is isolated esophageal eosinophilia. By definition, the pathology must be confined strictly to the esophagus.
So if the pathologist looks at the stomach biopsies and sees eosinophils there too,
Then the diagnosis changes completely. You are no longer dealing with EoE. You are likely looking at eosinophilic gastroenteritis, or a hypereosinophilic syndrome, or a parasitic infection, or even Crohn's disease. The therapeutic approach for systemic eosinophilia is radically different from the localized treatment of EoE. So the negative findings in the stomach and duodenum are just as critical for the diagnosis as the positive findings in the esophagus.
that is a brilliant diagnostic safeguard. Okay, so we've mapped the GI tract. We send the samples to pathology. What is the magic number? Because everything in surgery eventually comes down to a threshold.
To definitively diagnose EoE, the pathologist must identify greater than or equal to 15 eosinophils per high-power field HPF in the esophageal biopsies.
15 eosinophils per high-power field. That is the gold standard metric.
It is. They will also report on secondary histological features to confirm the chronicity of the inflammation.
Like what?
They look for basal cell hyperplasia, which indicates the basal layer is hyperproliferating to try and replace damaged tissue. They look for elongation of the lamina propria papillae reaching toward the surface. They look for those extracellular eosinophilic granules we discussed earlier, evidence that the eosinophils have degranulated and dumped their toxic proteins in the tissue.
And, of course, the subepithelial fibrosis from our friend TGFB.
Exactly.
Okay, let's synthesize where we are in the clinical timeline. We have our 34-year-old Caucasian male with a history of childhood asthma. He presented with food impaction. We pushed the impaction down or retrieved it. We put him on 40 milligrams of a PPI twice daily for 8 weeks. He failed. The dysphagia remained.
Classic progression.
We scoped him, noted some longitudinal furrows, and took biopsies from the proximal, mid, and distal esophagus, plus the stomach and duodenum. The stomach and duodenum were totally clear, but the esophageal biopsies came back showing 30 eosinophils per high-power field. We have satisfied all 3 legs of the diagnostic triad. We have definitively diagnosed immune-mediated eosinophilic esophagitis.
The diagnosis is locked in.
Now comes the hard part: management. How do we stop the demolition crew and restore function to this fibrotic tube?
The management of EoE is a triad in itself: diet, drugs, and dilation.
Diet, drugs, dilation, easy to remember.
The overarching physiological goal is straightforward: decrease the eosinophil count to reduce the inflammation and halt the remodeling. But executing that is incredibly demanding on both the patient and the clinical team.
Let's start with the dietary approach. Since this is an antigen-mediated disease, logically, if you just remove the antigen, the immune response stops.
In theory, yes. If a patient undergoes allergy testing and identifies a single specific trigger, say, isolated egg allergy, they eliminate eggs and the disease remits.
Seems simple enough.
But targeted elimination based on allergy testing is notoriously ineffective in EoE. The skin prick tests often just don't correlate with the localized mucosal response in the esophagus.
So you have to use a broader brush. The text discusses the 6-food elimination diet, the SFED.
Yes, it is an empiric elimination diet based on epidemiological prevalence. The patient must strictly and completely eliminate the 6 most common allergenic triggers:
Which are?
cow's milk, wheat, peanut and tree nuts, egg, soy, and seafood shellfish.
I want to pause and just recognize the reality of that prescription.
It's brutal.
Telling a 34-year-old adult to suddenly stop consuming dairy, wheat, eggs, and soy, I mean, that is effectively dismantling the entire standard Western diet.
It requires a massive lifestyle overhaul. Eating out becomes nearly impossible. Every single label must be scrutinized. The psychological and social burden of the SFED is immense, and compliance is a massive clinical hurdle.
But biologically it works. Wheat and dairy, particularly, have protein structures that frequently induce that Th2 response. But what if the SFED isn't enough? Or what if the patient is a pediatric case with severe failure to thrive and you need guaranteed mucosal healing immediately?
Then you move to the nuclear option of dietary management, the elemental diet.
I read this section of the clinical text several times because the surgical implications are profound. Break down what an elemental diet actually is.
An elemental diet removes all intact proteins entirely. The patient consumes a strictly liquid formula composed exclusively of free amino acids, simple sugars, and necessary fats and vitamins. Because the proteins are broken down into their elemental amino acid building blocks, the immune system simply cannot recognize them as antigens. It starves the Th2 cells of their trigger.
Clinically, the text states this is the most effective dietary intervention. It induces histological remission in the vast majority of patients. But there is a massive practical catch for the surgical team, right?
There is. The amino acid formulas are profoundly unpalatable. The taste and texture are often intolerable, especially for children, but even for highly motivated adults.
It's just too gross to drink all day.
Exactly. Furthermore, consuming enough volume orally to maintain basic caloric needs is incredibly difficult.
Which leads to a severe surgical intervention just to facilitate the diet.
Exactly. These patients frequently require the surgical placement of a gastrostomy tube.
A G-tube.
The G-tube directly through the abdominal wall into the stomach.
Think about the gravity of that. The esophageal inflammation is so severe, and the required liquid diet is so unpalatable that you are surgically placing a feeding port into their stomach just so they can bypass the immune reaction in their throat.
It illustrates the true severity of the fibrostenotic phenotype. And the follow-up for any dietary management is relentless. You don't just put them on a diet and assume it works.
Right, you have to verify.
Every single time a food group is reintroduced, say, you bring back wheat, after 6 weeks of remission, you have to perform another endoscopy and another set of biopsies to objectively measure the eosinophil count.
It's an endless cycle of scoping, which is why many adult patients and even pediatricians pivot to the second pillar of the management triad: pharmacological therapy.
For drugs.
We already discussed the PPI trial and its eotaxin 3 inhibition, but for the true immune-mediated EoE that fails PPIs, the American College of Gastroenterology has a highly specific recommendation.
The ACG strongly recommends the use of swallowed topical corticosteroids as the first-line pharmacological treatment. The typical regimen is an 8-week course.
The mechanism of delivery here is brilliant, but it requires a lot of patient education. Because these are drugs typically used for asthma, right?
Yes. We use medications like fluticasone propionate or budesonide. The dosage is significantly higher than typical asthma maintenance. For fluticasone, it's an oral suspension of 880 to 1760 micrograms per day. For budesonide, 1 to 2 milligrams per day.
But the key is the word swallowed.
Usually an asthmatic patient uses an inhaler to draw the aerosolized steroid deeply into the lungs. For EoE, we instruct the patient to spray the medication into their mouth and deliberately swallow it.
Or to mix a liquid ampule with a thickener, right, like honey or sucralose.
Yes, to create a viscous slurry and swallow that.
You are trying to physically paint the inside of the esophagus with the steroid.
Exactly. The goal is maximum topical contact time with the esophageal mucosa. Glucocorticoids are highly potent anti-inflammatories. They induce apoptosis program cell death in the eosinophils, and they heavily suppress the Th2 cytokine release.
And because it's topical, you avoid the severe side effects of systemic steroids like bone density loss, immunosuppression, and mood changes.
For the most part, yes. The main side effect to monitor is esophageal candidiasis, a fungal infection,
Right.
because you are locally suppressing the immune system in the esophagus.
But if the topical steroids fail, or if the patient presents with an incredibly acute, severe flare-up with massive weight loss and inability to swallow even liquids, you have to bring out the big guns.
Systemic steroids, oral prednisone, up to 60 milligrams per day. This will rapidly cool down the systemic inflammation, but it is not a long-term solution due to the toxicity profile.
That makes sense.
And frankly, any patient reaching this stage must be under the co-management of an allergist or immunologist to manage the broader atopic diaphysis.
Okay, we've covered the diet, we've covered the drugs. Now we arrive at the third pillar, the one that directly involves the surgeon or the interventional gastroenterologist, dilation.
This is the critical juncture.
The patient has mechanical strictures, the TGFB has laid down scar tissue, they are actively choking. The instinct, the mechanical, surgical instinct is to go in with a balloon catheter, inflate it, and forcefully stretch that stricture back open. Just plumb the pipe.
And this is exactly where the FRCS candidate must demonstrate absolute clinical maturity. The text contains a massive, non-negotiable warning regarding endoscopic dilation.
It is perhaps the most critical takeaway for avoiding catastrophic morbidity in this entire deep dive.
Endoscopic dilation is fundamentally contraindicated as a first-line treatment for an actively inflamed EoE esophagus. You must strictly defer dilation.
Let's explore exactly why. Because a junior trainee might look at a barium swallow showing a tight stricture and say, I can fix that in 10 minutes with a balloon.
And in doing so, they might literally kill the patient.
Yeah.
You have to recall the endoscopic visual of the crepe paper mucosa we discussed earlier. When the esophagus is actively inflamed, heavily infiltrated with eosinophils, and bathed in destructive granular proteins, the tissue loses all of its elasticity and tensile strength.
It becomes profoundly friable.
Extremely. If you take a high-pressure pneumatic balloon and forcefully expand it inside a tube made of wet crepe paper, the tissue doesn't stretch. It tears.
The risk of transmural esophageal perforation is astronomically high in an unmanaged EoE patient.
Off the charts.
And an esophageal perforation isn't just a minor complication, it is a life-threatening surgical emergency. You are spilling salivary enzymes, bacteria, and food directly into the mediastinum, the space in the chest containing the heart and major blood vessels.
Mediastinitis has a terrifying mortality rate.
Which is why the protocol dictates patience. You must defer dilation until the patient has undergone a full course of dietary or pharmacological therapy. You must cool the inflammation first.
You give the fluticasone, you wait the 8 weeks, you reoscope. Only when the crepe paper has healed, when the mucosal integrity is restored, do you assess the mechanical stricture.
Because the stricture might still be there. The steroids stop the inflammation, but they don't dissolve the mature collagen laid down by the TGFB.
Correct. The fibrostenotic remodeling is often permanent. So once the mucosa is cool and resilient, then, and only then, you can proceed with endoscopic dilation to fracture the underlying fibrotic rings.
But even then, you must proceed with extreme caution, right?
Oh, absolutely. You use a graduated balloon catheter or a wire-guided savory bougie, and you dilate millimeter by millimeter across multiple sessions.
You do not try to achieve a normal lumen diameter in a single sitting.
Never. The goal is symptom relief, usually a diameter of 15 to 18 millimeters, not anatomical perfection. And even with a cooled-down mucosa and gradual dilation, the complication rates are still higher than in normal esophagi.
So informed consent is a big deal here.
Huge. You must explicitly warn the patient during consent about severe post-dilation chest pain, bleeding, and the persistent, albeit reduced, risk of perforation.
It requires immense restraint.
Yeah.
Before we close the book on the clinical text, a master clinician also needs to know when they are wrong. We touched on the stomach biopsies earlier, but I want to explicitly run through the differential diagnosis list.
Good idea.
Because if you lock onto EoE and ignore the other possibilities, you miss the boat entirely.
The differential for esophageal eosinophilia and dysphagia is broad, and each requires a different approach.
Let's dissect a few of the major ones. What about achalasia? Both present with dysphagia to solids and liquids. Both have a mean age of presentation in young adulthood. How do you separate them?
Achalasia is a motility disorder, not an inflammatory one. The lower esophageal sphincter fails to relax due to the degeneration of the myenteric plexus.
Okay.
Endoscopically, you don't see crate paper or trachealization in achalasia. You see a dilated, boggy esophagus with retained food, tapering to a tight bird beak at the sphincter.
And the manometry would look different too, right?
Exactly. An esophageal manometry study will show absent peristalsis in achalasia, whereas motility is generally preserved in early EoE.
What about Crohn's disease? Crohn's can affect any part of the GI tract from mouth to anus.
Crohn's is characterized by transmural inflammation through the entire wall of the organ, not just mucosal eosinophilic infiltration. Pathologically, you are looking for non-caseating granulomas, not sheets of eosinophils.
Right.
And endoscopically, Crohn's presents with deep serpiginous ulcers and cobblestone mucosa, often with skip lesions leaving normal tissue in between.
The clinical text also lists celiac disease, connective tissue disorders like scleroderma, drug hypersensitivity reactions, graft versus host disease, and various forms of vasculitis.
It's a very intimidating list, but this is exactly why the rigid diagnostic triad exists.
The triad is your anchor.
Yes, if you strictly adhere to the protocol, the clinical history looking for atopy, PPI trial to evaluate the STAT6 and eotaxin 3 response, and the geographic biopsy mapping of the esophagus, stomach, and duodenum, you'll systematically and definitively eliminate every single one of those differentials. The protocol is your safety net.
So, what does this all mean? When we synthesize the entire clinical picture of eosinophilic esophagitis, it reveals that treating this disease is the ultimate exercise in multidisciplinary medicine.
It really is a team effort.
It requires the gastroenterologist's keen eye to identify the subtle longitudinal furrows and take the precise geographic biopsies. It requires the pathologist's meticulous counting to identify the threshold of 15 eosinophils per high-power field. It requires the allergist to manage the underlying systemic Th2 atopic diathesis. It requires the dietitian to guide a patient through the sheer psychological toll of an elemental diet.
And perhaps most importantly for our listener,
Yes, it requires the surgeon to possess the clinical maturity to know exactly when to step back, to defer the mechanical dilation, to hold off on inflating the balloon until the medical team has extinguished the fires of inflammation. That restraint, that deep understanding of the tissue's biological reality, is what separates a mechanical technician from a master clinician.
I couldn't agree more. Mastery in surgery is often defined by knowing when not to operate or when to delay an intervention. It is about respecting the underlying cellular biology before attempting to alter the macroscopic physical structure.
The tension between the microscopic cellular war and the macroscopic physical reality of the patient is exhausting. We spent the last 45 minutes entirely submerged in a highly clinical microscopic world.
We went deep.
We did. We have been dissecting the 5q22 region, tracking interleukin-13, counting eosinophils, and worrying about the sheer stress on mucosal friability. It is intense, chaotic, and frankly, anxiety-inducing internal warfare.
It's a lot to hold in your head.
But you, the listener, did something very interesting when you submitted your study materials for this deep dive. You included a totally different kind of source in your stack. It serves as a profound visual palate cleanser.
It's a remarkable shift in tone. Let's examine the image you provided.
Okay, it's a photograph of a stone memorial wall standing quietly in this lush, incredibly manicured, serene garden. The central monument is sturdy, grounded, and features a plaque that clearly reads, Victoria Cross Indian Recipients.
Right.
Below that imposing heading, there are lists of names and dates carved into the stone. The resolution of the image doesn't allow us to read the individual names from this distance, but the specific names almost aren't the point. The structure, the permanence, and the intent of the space are undeniably clear.
They are. If we analyze the setting based solely on the visual data in the photograph, the composition is highly intentional.
How so?
You have these low, rustic stone walls flanking the entrance. They aren't defensive. They are guiding, drawing the eye and the visitor inward. There is a neatly paved, stable stone pathway leading directly up to the central monument.
And framing this entire scene of gray stone is a vibrant, thriving burst of flora. You can clearly see bright yellow marigolds lining the pathway, providing this brilliant warmth, and behind them, tall, striking purple agapanthus. All of this is set against a deep, mature, anchoring backdrop of green trees.
After spending an hour talking about Th2 cells acting as rogue generals and TGFB demolition crews paving over the throat with scar tissue, looking at this image feels like finally exhaling.
It is just peaceful. It's the absolute antithesis of the biological chaos we just studied.
If we connect this to the bigger picture, especially for you, the listener, who is currently deep in the trenches of FRCS exam preparation, there is a powerful thematic resonance here.
I see where you're going with this.
This is a memorial.
Yeah.
It exists to acknowledge immense dedication, profound sacrifice, and a history of unimaginable service. The Victoria Cross is the highest military decoration awarded for valor in the face of the enemy.
Right.
The individuals whose names are carved into that stone-faced, chaotic, terrifying realities, and they gave everything of themselves in response.
They fought visible, macroscopic wars. And we are absolutely not equating studying for a surgical exam to military combat.
No, of course not.
But we are juxtaposing the nature of dedication. You are currently sacrificing a tremendous amount. The late nights, the missed family events, the sheer mental endurance required to memorize the cytokine cascades and the biopsy protocols.
It's a grueling process.
You are subjecting yourself to this discipline so that you can intervene when a patient's own biology turns against them. You are training to fight an invisible microscopic war on their behalf.
It serves as a necessary moment of grounded reflection. In medicine, it is incredibly easy to lose the forest for the trees.
Oh, totally.
You get so hyper-focused on the number of eosinophils per high-power field or the exact diameter of the dilation balloon that you risk forgetting the human being attached to that esophagus.
The guy in the restaurant choking on his chicken.
Exactly. You are immersing yourself in the microscopic details, the genetics, the interleukins, the strictures, so that you can provide macroscopic relief, actual peace, to the person sitting terrified in your exam room.
Just as that memorial garden provides a serene, highly ordered space to reflect on the chaotic, brutal realities of historical conflict, it takes the chaos and gives it structure, meaning, and peace.
It is a beautiful and necessary contrast. The microscopic chaos of the disease versus the macroscopic serenity of the memorial. The biological warfare versus the disciplined peace of the surgeon's mind.
So as you close your textbooks tonight and look toward your exam, let's synthesize the critical takeaways from our clinical deep dive. What are the absolute non-negotiables you must carry with you?
Let's review.
First, the paradigm shift. Eosinophilic esophagitis is a distinct chronic antigen-mediated immunological process. It is not just stubborn GERD.
Remember the genetic origin. Lock the 5q22 region on the male X chromosome into your memory. Understand the TSLP pathway that stimulates the Th2 cells, which in turn release the IL-13 and eotaxin-3 that recruits these eosinophils to a tissue where they fundamentally do not belong.
Remember the rigid diagnostic requirements. It's a triad. You must evaluate the clinical presentation impaction in adults. Insidious failure to thrive in kids. You must perform the PPI trial, understanding that PPIs block the STAT6 pathway to reduce eotaxin-3. And you must execute the geographic biopsy mapping. Proximal, mid, and distal esophagus to find the patchy disease, plus the antrum and duodenum to definitively rule out systemic eosinophilic gastroenteritis.
And the magic number is greater than or equal to 15 eosinophils per high-power field.
And crucially, for your surgical practice and your exam, remember the rules of management. The treatment triad is diet, drugs, and dilation.
You utilize the 6-food elimination diet or the elemental diet to remove the antigen trigger. You utilize swallowed topical steroids like fluticasone to coat the mucosa, induce eosinophil apoptosis, and cool the inflammation.
And the absolute surgical rule. You must strictly defer endoscopic dilation until the tissue is medically cooled down.
You do not inflate a balloon inside an esophagus lined with inflamed crepe paper mucosa. You wait, you heal the tissue, and only then do you use a graduated balloon to address the permanent fibrostenotic strictures caused by TGFB.
Mastering this specific condition, truly understanding the why behind the mucosal friability, the how of the eotaxin-3 homing beacon, and the when for mechanical dilation is exactly what separates a competent technician from an exceptional FRCS-certified master clinician.
It is about knowing when to act with your hands and when to let the biology and the medicine do the work.
We want to leave you with a final, lingering thought based on the clinical text. We learned today that a single cutaneous exposure to an antigen, a specific pollen spore landing on the skin, or a minor contact allergy, can trigger a systemic immune cascade that ultimately results in a rogue demolition crew permanently remodeling the tissue inside the esophagus.
It's a profound thought.
As you move forward in your surgical career, repairing hernias, resecting bowels, and dilating strictures, what does that incredible systemic domino effect tell us about how we must view the profound interconnectedness of the human body's mucosal immune system?
It strongly suggests that the era of looking at a single organ in isolation is over. Every surface is talking to every other surface.
We started today talking about how we like our medical diagnoses to be like engineering a broken bone, a clean white line on an x-ray, binary and fixable. But in the muddy, complex waters of chronic inflammation and mucosal immunology, true precision doesn't come from a simple picture. It comes from understanding the chaos.
Well said.
Keep studying, keep looking at the bigger picture, and good luck on the FRCS. We'll see you on the next deep dive.